Okay, so I'm going to start here with my assignment. So I had patient number 5. Here's some medications. This column has the acute problems given in the hospital, and then these have the hospital and home meds, so more chronic issues. And then here are the labs and vitals. Now we're going to go take a look at these meds. I did a little chart here. So these ones on the right-hand side, this says this is my acute problem used in the hospital. So the first one is guanfacine. This is an expectorant, so it's for productive lung coughing. Increases the volume of secretion so that you can easier expel the mucus, and we need to know that it can cause rebound congestion if it's used more than 7 days. Next one, doxycycline. That's an antibiotic and broad spectrum. Static, so it stops the growth. Things to keep in mind: it should never be given to pregnant women and interacts with dairy products, calcium products, and digoxin. Albuterol sulfate, that is a lower respiratory drug, beta-2 receptor agonist, and this one is for a rescue inhaler, so it helps with the dilation of bronchioles in the lungs. Things to do: caution in hypertension patients. Interaction, non-cardioselective beta blockers. So this is propranolol and labetalol, and it is the rescue inhaler. Symbicort is our final one. That's the acute med, and this is another bronchodilator, and it's composed of 2 drugs that we learned about in pharm. So there's bunoside and this formoterol. Bunoseride is the one we mainly talked about. This is the bronchodilator. It's a corticosteroid, so things we got to make sure we do with this one is the rinsing of the mouth after they take it, because it prevents thrush. So reasons, some things that I think is happening with these acute meds. So this is a lung issue. So maybe things that cause productive coughs could be pneumonia, COPD, anything that really creates that gunk and mucus production, COPD in particular. Next one, doxycycline, maybe an infection because it's antibiotic. Albuterol sulfate is a muscle relaxer, so something that would help relax muscles, so like asthma, COPD. Those are some thoughts there. And then the Symbicort, another, again, that bronchodilator, so again, another lung issue. So stabilizes the air longways in inflammation during an acute respiratory flare-up. So from these meds, these 4 that are in the hospital, the new ones, 3 out of the 4 are all lung related. So I think one of my priority problems, the reason why my patient is here in the hospital, is some sort of lung issue. And we will go scroll down to my concept map, and I'll show you. My middle was COPD exacerbation. Okay. Now we're going to go back up and talk about the other meds that the patient is taking inside the hospital as well as at home. So more chronic issues. Okay. Pacerone, also known as amio. This is for AFib. It's an emergency cardiac med. Things to know: never give to patient with bradycardia or has a current heart block. Caution in patients with already existing lung problems. So my patient probably. So we need to be cautious with this med. So AFib, VFib type people. So I think my person might have AFib or VFib. Amlodipine, this is a calcium channel blocker. Used for antihypertensive, so lowers the blood pressure. Needs to keep an eye out for hypotension, and interacts with grapefruit and statins, which is a thing I'll bring up later. So again, I think my patient has hypertension. Another one, aspirin. This is the antiplatelet, so a platelet slicker. Things to watch out for: it's adult use only because it gives kids Reye syndrome, can cause GI bleed, so you have to give it with food. And you can't give it in the 3rd trimester, and it can cause ototoxicity. Again, I put this with AFib. Atorvastatin, that is a lipid-lowering agent, so my person, I think, has some sort of atherosclerosis, high lipid content as well. So things to know about this one: discontinue if weakness happens because it can cause rhabdo. You can't have grapefruit juice while taking this, and you have to report that muscle pain to your provider. And it's not effective in patients who have bad liver functions. Keep going down here, some more furosemide. That's my diuretic. So I think some sort of liquid buildup, fluid buildup is occurring in my patient, which we'll talk about later too. Caution, things to know. So you have to monitor potassium levels because it's a potassium wasting diuretic. You have to give slowly because it's have a higher risk for ototoxicity and hearing loss. You take it in the morning because you want your patient to not be peeing at night. And don't use, it can be used for kidney patients because it works even on bad kidneys. Treats flash pulmonary edema and edema-related heart failure, which we'll talk about too. Glucotrol, also called glipizide. This is a oral hypoglycemic, so it's a sulfonylurea. It's for type 2 diabetes only. So I think my patient has type 2 diabetes as well. Often combined with metformin for optimal use, only works in a working pancreas, so type 2, and taken within 30 minutes of the first meal of the day, so taken within breakfast. Deltazone, also known as prednisone, is another lower respiratory drug that's a glucocorticosteroid. So this is our second steroid. If we go back up here, this bunoside was a steroid as well. So we have two steroids. With this one, so we have to watch out for steroid effects because it can increase glucose. It's a higher infection risk and can cause osteoporosis. Take it with food. Again, another high infection risk. And my thought is COPD is inflammatory versus the other guess was asthma. Asthma is inflammatory too, but COPD, more importantly, is more inflammatory. So I'm ruling out asthma and I'm going towards COPD now. Metoprolol, the final med, is a beta blocker, cardioselective. It only works on beta 1 cells, which is on the hearts. Helps lower the heart rate, slows contractility. Things to watch out for is, again, low blood pressure, dizziness, fatigue, hypoglycemia as well here. You need to check heart rate and blood pressure before you give this med, avoid sudden changes in positioning, and education on the lowered libido effects. So I think my person has some sort of hypertension as well. Okay, now we're down at my map, and here's my center. I think my person has come to the hospital with this problem, COPD exacerbation. What tells me this are these 3 meds here in particular that were acutely used just in the hospital. That's why they are in this red highlighted color. So Symbicort is a steroid, albuterol is my emergency inhaler, and this guanfacine is that COPD, like getting the gunk out, and COPD has that mucus creating layers. This person is also on this prednisone, deltazone steroid. So with a combination of 2 steroids, they counteract the inflammatory process of COPD to improve ventilation and the lowered the pressure in the pulmonary artery pressures. Okay. So with that in mind, we have to be really careful because 2 steroids is a lot and it can increase the sugar. And my person is already, I'm pretty sure, because they're on this glucotrol, already type 2 diabetic. So here's my lab value that has to do with sugar. Glucose is at right now 181, which is pretty high. And then the steroids also increase the infection risk. So I tied that to my doxycycline. So I think doxycycline in this case is being used prophylactically. I don't think there's an infection, but there definitely could be with the use of 2 steroids. So I put my lab of white blood cells at 14.12, which is a little high, not crazy high. And then my temperature at 100.5, which again is a little high, but not extremely. So again, I'm not sure if there's a infection right now. I know there's inflammation because of the COPD, but not necessarily an infection. So yeah, that's an explanation for my doxycycline for the double steroid use, and then the blood sugar already being kind of high. So we're preventing pneumonia. We're preventing that pneumonia. Some assessments for my COPD exacerbation. My person would be having a productive cough and wheezing, hypoxia, so cyanosis, bluish color around the lips and mucous membranes, dyspnea, difficulty breathing, accessory muscle use when they're trying to breathe, and then finger clubbing from that hypoxia. Some labs to look at, CBC for the ABGs that relate to O2 and CO2 ratios, as well as the pH. Okay, now I'm going to talk about my right-sided heart failure. So COPD has a direct impact on the right side of the heart failure, and I will explain that by going down here. So when you have a COPD, you have an increased mucus production. This increases inflammation. All your inflammatory cells come in here and try and fight off that mucus, which inevitably will create low oxygen status, so decrease your ventilation, decrease breathing, and increase hypoxia. So the O2 cannot diffuse as well into the alveoli, into the bloodstream. So this then stimulates pulmonary artery vasoconstriction, also known as pulmonary artery hypertension. Then this increases the pressure in the right ventricle of the heart, which then, if this happens over amount of years, this will lead to right-sided heart failure. Also, the name for this is cor pulmonale. So things related to right-sided heart failure that I would see in my patient is JVD, ascites, hepatomegaly, splenomegaly, and then edema, especially in that peripheral leg, sacral leg area. So COPD, I looked in my patho book for this. COPD puts pressure on the pulmonary artery, creating hypertension. Now the blood flow from the right side of the heart has to push against that resistance in order to get to the lungs. The force can become too great to push against, and backflow occurs into the right side of the heart. Subsequently, that'll back up even further into the venous system, creating all of that edema. Now the lungs can't oxygenate the blood, and the CO2 builds up, which will lead to hypercapnia, which in my case is my most severe thing that could happen. So this person could have a buildup of CO2 so bad that they die because of that built up. Okay, now we're back in my concept map. We're going to zoom in here for the right side heart failure, that cor pulmonale. So meds for this one is this furosemide, my diuretic. We need to check potassium. Metoprolol, that beta blocker, cardioselective. So I did a little rationale here where it couldn't, if my med was labetalol or propranolol, that would not be the right one because those interact with the beta-2 receptors in the lungs and would increase the vasoconstriction. So I know that my person has to be a COPD patient because they're on metoprolol. Some labs here, BNP, this was super high, 1,312. So that's extremely high. So that indicates that there is some sort of stretching of the heart muscle, some hormone being released and saying, hey, I'm being way too overstretched. And so that, in my mind, connects right to heart failure. Again, those assessments, which we talked about earlier. Okay, some other things to talk about. The meds Pacerone and aspirin has directly to do with AFib or VFib, which again can contribute to heart failure. And then we go over here to hypertension. That connects really well to heart failure as well. And I know my person's on amlodipine, my calcium channel blocker, and my blood pressure right now was 176/87. Needs to be examined because my person's also on a statin and they interact. And then there's also an effect of pulmonary edema and heart failure. So I need to question my doctor on that one. My person's type 2 diabetic. He's taking, or she is taking, glucotrol. And the A1C is at a 7.9, which is a little high, but not crazy high. Some labs, the kidneys are directly affected by diabetes. So things to look at, the creatinine at 1.52, which is high. GFR at 4.43, which is okay. Hemoglobin at 9.0. And this could be low due to a kidney disease, which I connected up here. So mainly due to a high creatinine level and low hemoglobin. So I think my person has some sort of kidney disease because the hypoxia and the oxygen not getting from the blood to the kidneys can create some sort of dysfunction where it can't cycle out the creatinine, so that's why it would be high. And then as well as a low hemoglobin because a stressed kidney would secrete less EPO, which would decrease the amount of red blood cells, which directly affect hemoglobin. Worst case scenario, my person can have CO2 poisoning, which is hypercapnia, acute respiratory failure. The CO2 accumulates and cannot exchange, get out of the system. Things that would indicate this is happening: headache, dizziness, level of consciousness change, confusion, seizures. This is all because the brain lacking oxygen. Preventing would be the meds, placing correct positioning, suctioning the secretions, possibly intubating them. And if it gets worse, and worst case thing, BERT, and then giving the meds super, super fast. And here's just a really quick page of my labs and vitals connected to each other. And just to clarify, my red COPD is the main problem. These other blue boxes are all the chronic problems he's had prior coming to the hospital.